Hello everyone. Now that we've learned how to assess the normal pelvis using transvaginal ultrasound, I'll be digressing a bit from gynecological pathology and speaking about the ultrasound appearance of normal early intrauterine and ectopic pregnancy. Now, whenever we begin scanning the pelvis, we understand that the transabdominal approach gives us a wide field of view and helps in getting a general overview of the pelvis. But the workhorse is, of course, the transvaginal ultrasound, and it is indispensable, especially when we are looking at early intrauterine pregnancy, because at this point of time, we are looking at very minute structures which can only be seen by using high frequency ultrasound. Now, this is just to show you a difference between the appearance of transabdominal and transvaginal scan. Now, this is a picture of the Haifa gardens in Israel. And as you can see here, you can see a lot of stuff and get a general overview of the garden from this picture, which is similar to what a transabdominal image looks like. But if you are to see this temple in the center of this garden, you would need to go further, and that is what exactly that we do in transvaginal ultrasound. We approach the area of interest and view it at a very close distance so that we can see things more clearly. So this is the difference between a transabdominal ultrasound, which gives you a general overview of things, and a transvaginal ultrasound, which takes you closer to the area of interest and gives you images with finer detail. Now, we all know how to assess the normal pelvis. This is just a brief recap. We keep the probe at the introitus and start looking at the ultrasound screen. We see the cervix, bring it in alignment with the endometrial cavity, and first see the uterus in the sagittal section from one end to the other. Here we are looking for a gestational sac because we are seeing or assessing a patient with early uterine pregnancy. And of course, then we make it a point to check in the other plane, that is the axial plane, remembering to sweep right from the fundus down to the cervix. This is how we assess the uterus. And when we are to look at the adnexa, we go to the cornual end, try to follow the leash of vessels arising from the cornua, look for the ovary in the pelvis, and we don't stop at the ovary but make an effort to look laterally beyond the ovary, because sometimes an ectopic gestational sac in the tube can be lateral to the ovary. Now, first coming to the normal appearance of an intrauterine gestation. We understand that the following components are seen sequentially in a normally progressing intrauterine gestation. Coming to the gestational sac. Gestational sac can be a round or oval anechoic structure which has a typical echogenic rim around it. A normal sac is situated in the upper half of the uterine cavity. It's eccentric in location, and it's actually not in the cavity, but it's embedded in the endometrium. A gestational sac can be seen as early as 4.5 weeks by transvaginal ultrasound. Now, this is a clip showing you the appearance of an early gestational sac of size 2 millimeters within the endometrium. You can appreciate this anechoic structure within the endometrium. It has an echogenic rim, as you see here. This is the round anechoic structure, around 2 millimeters in size, with an echogenic rim. To see it better, you can appreciate in the still image. This is the endometrium, the echogenic endometrium, and you see this eccentrically located anechoic round structure with this echogenic rim, which is a normal intrauterine gestational sac at 4.5 weeks, seen by transvaginal ultrasound. Now, always remember that whenever you see an anechoic round structure in the endometrium, make sure that you have identified this echogenic rim. And I will be highlighting or stressing this point over and over during the course of my presentation. Now, these are two signs which were described way back in the 1980s on transabdominal sonogram in order to confirm whether a structure was truly a gestational sac or not. One is the intradecidual sac sign. As you can appreciate, again, this is a transvaginal longitudinal image of the uterus. This is the thickened echogenic endometrium. This anechoic structure with the echogenic rim is the gestational sac. And you can see that this sac is present within the decidua. So this echogenic line that you see is that of the endometrial cavity. and the sac will be present within the decidua, as you see here, situated eccentrically within the endometrial cavity. The double decidual sac sign is something which we see when the gestational sac becomes a bit bigger. And why it is called as double decidual sac sign is because you see two rings of tissue around the sac. This first ring is formed by what we call as the decidua capsularis. And when the decidua capsularis opposes or touches or comes in contact with the decidua parietalis, we get the second echogenic ring. So first, this is the endometrial cavity, and you can appreciate the intradecidual sac sign. Second, this is the first ring of the double decidual sac sign formed by the decidua capsularis, and the second ring formed by decidua parietalis. Now, just to recap what the decidua parietalis, capsularis, and basalis stand for. So if this red structure is the gestational sac, the part of the decidua which covers the gestational sac and lies towards the endometrial cavity is the decidua capsularis. Whereas the part of the decidua which forms the base or which will form a part of the future placenta is the decidua basalis. It's towards the uterine serosa. And finally, the rest of the decidua is termed as decidua parietalis. Now, this is just a video to show you real time the intradecidual sign. So as you can appreciate, this is the endometrial, or rather the decidua or the endometrium, which is thickened. And this irregular anechoic collection of fluid should not be mistaken for a gestational sac. This is nothing but fluid in the endometrial cavity, which can often be seen along with the gestational sac, because remember, there is some amount of implantation bleeding that occurs when a sac is implanted in the decidua. This should not be considered as something ominous and cause undue alarm. Now, this is the true gestational sac, which you can see how it is embedded within the decidua. So this is the intradecidual sac sign. You can appreciate it is round anechoic structure, but what is most characteristic and which helps in confirming that this is indeed a true gestational sac is this echogenic rim of tissue. It's formed by a combination of the chorion and decidua around it. So now that you've got a flavor of how a normal gestational sac looks like, let's move on. This is just an image to show you the various kinds of decidua that I spoke about. So the decidua which would be covering the sac towards the cavity would be decidua capsularis. The part of decidua towards the serosa would be decidua basalis, and the rest of the decidua would be decidua parietalis. So when this decidua capsularis fuses with the decidua parietalis and this fluid is obliterated, we would get the typical double decidual sac sign. So it would be seen when the sac is a bit more big in size. Now, how do we measure the mean sac diameter? Remember, if we don't see a fetal pole or any other structure, we need to date the pregnancy, and this is done by measuring the mean sac diameter. Now, to measure the sac diameter, we have to measure, again, just like any other structure, we have to take 3 dimensions in 2 perpendicular planes. First, we take a dimension in the longitudinal plane or in the plane in which the sac appears the longest. So here we take 2 measurements, inner to inner, excluding the echogenic rim, as you see in this image. So 2 perpendicular measurements are taken, one side to side and the other anterior-posterior. And then from this position, we will rotate the probe 90 degrees anti-clockwise to get the transverse plane, and just take the third measurement side to side as we do in any other structure in the pelvis. Now, 3D is seldom used, or rather rarely used, when we are assessing a normal intrauterine gestation. But sometimes when the sac is situated very eccentrically in the uterine cavity and you're not sure whether it is truly endometrial in location or whether it is extending beyond the endometrium, then you can resort to use of 3D, as we've done here. We've used 3D Omni View. So this is a sagittal section of the uterus, and we've drawn a trace so as to obtain a coronal plane of the uterus, as you can see here. So this anechoic structure with the echogenic rim around it is first a true gestational sac. And second, if you look closely, though it was situated eccentrically on 2D ultrasound, on 3D we are quite sure that it's enclosed on all sides by the echogenic endometrium, and it's not extending beyond the endomyometrial junction towards the interstitial part of the tube. So this is a truly intrauterine, normally sighted gestation. Coming to the next structure, now after the appearance of gestational sac, the next structure which we can see within the gestational sac is, of course, the yolk sac. Now, if you see the presence of a yolk sac within a gestational sac, then it confirms that that structure is truly a gestational sac. And a yolk sac can be seen as early as 5 weeks on transvaginal sonography at a mean sac diameter of 5 to 6 millimeters. It is again a round structure with an anechoic center and an echogenic wall. Now, once it appears between 5 to 6 weeks, it gradually increases in size to reach a maximum diameter of 6 millimeters at 10 weeks of gestation, following which it decreases in size and usually disappears after first trimester. Now, it's important to remember that you can see the normal yolk sac between 11 to 14 weeks when you're performing the NT scan, and you should not mistake this anechoic structure with a thick wall for some kind of a cyst within the gestational sac, because we've often seen some referrals of people talking about some cyst seen within the gestational sac in the 11 to 14 week scan when it was nothing but a normal yolk sac. Now, this is how a yolk sac looks like initially on transvaginal ultrasound. You can appreciate this faint structure with an anechoic center and an echogenic wall at 5.5 weeks. It gradually increases in size. Now you can appreciate it more clearly with an eccentric embryo close to it. And finally, a bigger yolk sac at 8 weeks of gestation. Coming to measuring the yolk sac, it is measured in a similar fashion as the gestational sac. One can either take a single measurement in the plane where it appears the biggest, inner to inner measurement, or just like the gestational sac, one can take an average of 3 diameters measured in orthogonal planes. So you take the first dimension in the sagittal plane like this, the second dimension perpendicular to it, and then rotate the probe 90 degrees anti-clockwise to get the transverse plane and take the third measurement from side to side as you see in this picture. The next structure that we can see within the gestational sac is the amnion. As you can see in this illustration, this is the gestational sac. This relatively more red area around the gestational sac is what that echogenic chorionic rim that I allude to is. Then we have the yolk sac, we have the embryo, and this embryo is enclosed by this thin membrane or envelope, which is known as the amnion. It can be seen at around 6.5 weeks with transvaginal ultrasound. This amnion contains amniotic fluid, which is typically anechoic. The amniotic cavity is separated by this amnion from the chorionic cavity or the extraembryonic coelom. So we have the embryo, which is enclosed by the thin envelope of amnion and is present in the anechoic amniotic fluid. And outside the amnion, we have this area, which is known as the extraembryonic coelom or the chorionic cavity. And it is within this chorionic cavity or extraembryonic coelom that the yolk sac is situated. So yolk sac is an extraamniotic structure. This is important to know so that you don't mix up the yolk sac with an umbilical cord cyst, because an umbilical cord cyst would be present within the amnion. Also, as the gestational sac or the amnion grows, there is fusion of this amnion with the chorion, which results in obliteration of this extraembryonic coelom or the chorionic cavity by 12 to 16 weeks of gestation. So this is just to show you the normal appearance of amnion on transvaginal ultrasound. You can see this thin echogenic envelope, which is encasing the embryo. Note the anechoic amniotic contents. And you can see this area would be the extraembryonic coelom or the chorionic cavity, which is usually more echogenic. It has some echoes normally present within it. Sometimes these echoes can be even more conspicuous, especially with high resolution transvaginal probes, and one should not again mistake them for some kind of a hemorrhage and cause unnecessary anxiety or alarm. Now this is a clip to help you appreciate the amnion. You can see here this amnion is this thin envelope which is surrounding this embryo. This area outside the amnion would be the extraembryonic coelom, And if you look closely, you can appreciate this yolk sac, an echogenic structure with an anechoic structure with an echogenic wall, which is situated outside the amnion in this extraembryonic coelom. So you must be aware as to where the normal location of the yolk sac is so that you don't confuse it with something else. Now, coming to the embryo, it is first visible at around 5.5 to 6 weeks on transvaginal sonography. As we said earlier, it is situated at the periphery of the yolk sac and initially gives a signet ring appearance. It is smaller than the yolk sac to start with, and this is the typical signet ring appearance of the embryo attached to the periphery of the yolk sac. Now, embryo is featureless before 7 weeks. By this, what I mean is that you cannot differentiate the crown or the rump in the embryo before 7 weeks. Now, this is just an example to show you an embryo with a CRL of 2 millimeters seen at 6 weeks on transvaginal ultrasound. Now, this is a bigger embryo, as you can appreciate here, and it is no longer featureless. You can identify that this is the crown, which is identified by the presence of anechoic rhombencephalon or the future hindbrain within it. So if you see this anechoic structure in one end of the embryo, do not get alarmed. This is the normal rhombencephalon, and it helps you in identifying the crown or the head part of the embryo, whereas this diametrically opposite part would be the rump. So if you have to measure the crown rump length, you would draw a line joining the crown with the rump. This echogenic envelope that you see would be the amnion. So this would be the amniotic cavity. And outside the amnion would be the extraembryonic coelom or the chorionic cavity, which, as you can see here, contains the yolk sac. This linear structure that you see arising somewhere from the middle of the embryo is the connecting stalk, which will ultimately form the umbilical cord. So umbilical cord would be present, umbilical cord cyst would be present within the amniotic cavity in relation to this structure. And so a yolk sac should not be confused with an umbilical cord cyst. Coming to measuring the embryo. Now, when the embryo is featureless, as you see here at 6 weeks, you can't really differentiate the crown or rump, and so you just take the maximum measurement of this nubbin of tissue that you see. Now, after 7 weeks, when you can see the crown and the rump better, what you measure is actually not the crown rump length, but the neck rump length, because crown is actually, or the head is this part. But if you were to take this measurement, it would result in underestimation, and what you measure is the longest part of the embryo before 8 weeks, and that would be actually be the neck rump length, because if you were to take this measurement, it would result in underestimation of the length of the embryo and hence wrong call of the gestational age. And after 8 weeks, when the hyperflexion of the embryo resolves, then it's easier to measure the crown rump length. Now, this is a coronal section of the embryo, and what I'm trying to show here is again the normal rhombencephalon, which should not be mistaken for any brain cyst or anything. This is something that you see normally in an embryo before 10 weeks of gestation. Now, this is just to show you the correct measurement of the hyperflexed embryo before 8 weeks. And what this actually is the neck rump length, because this would be the crown rump length, but it would be less than the maximum length of the embryo, and this would result in underestimation of gestational age. So before 8 weeks, though we call it as CRL, it is actually the neck rump length that we are measuring. And after 9 weeks, when the hyperflexion resolves, as you see here, then we measure the crown and the rump correctly, as you can see here. So always we have to measure the maximum length of the embryo in order to get the correct gestational age. We are all aware of the guidelines for measurement of the crown rump length after 10 weeks. We need to take a midline sagittal section of the whole fetus in a horizontal orientation with appropriate magnification so that the crown and the rump are identified clearly. Fetus should be in a neutral position, and once we can identify the crown and the rump clearly, we draw a line from the crown to the rump, getting the maximum crown rump length of the fetus. Now, cardiac activity in the early pregnancy can be assessed subjectively in that you just hold the probe still and look for any kind of flicker or movement in the embryo, as you can see here. So we can appreciate normal cardiac activity in this embryo of CRL 2 millimeters at 6 weeks. However, we can also do an objective measurement if we want to get the heart rate, and this is done by using the M mode. Remember, we do not use color or pulse Doppler in the embryo because the heating effects of these can be detrimental to the developing embryo, and we do not want to cause any harm. So, what is recommended is to use M mode, and it's fairly easy to use if you understand how it is to be done. The main thing when trying to place or before placing the M mode cursor is that you must optimize your image, and more magnified your image is, the better you're able to see the area on which you're going to place the M mode cursor, and better the trace that you have. So this is an embryo at around 7 to 8 weeks of gestation. We have magnified it well so that we understand where the heart is, and then we just place the M mode cursor across the in such a manner that it passes across the heart, and this flicker of movement that we get in this trace is the heart rate. Since we see the waves very clearly, all that we need to do is just place our calipers at the beginning of one and the second wave, and the machine will automatically calculate the heart rate for us, which was 161 beats per minute in this case. Now, as you can see here, this is a curve showing you the variation, rather the normal variation in the fetal heart rate with gestational age. So please remember, it is not unusual to get a heart rate as low as 100 beats per minute between 6 to 7 weeks, and this should not be labeled as bradycardia. You must be aware that initially the heart rate is low and then it picks up so that it reaches a peak at around 8-9 weeks, where it can be as high as around 170 beats per minute. So that should also not be mistaken for fetal tachycardia, because what we are classically taught is that the normal fetal heart rate is between 120 to 160. But that is the fetal heart rate. In embryo, initially we have some degree of bradycardia, the heart rate then rises, reaches a particular level, and then finally, after 10 weeks, we get a stable heart rate ranging between 120 to 160 beats per minute. So this is something that we should be aware of before we start measuring the heart rate and interpreting. Now, what are the pitfalls or the various structures that can be mistaken for a gestational sac? These are mimics of gestational sacs, and what they would be certain anechoic structures that you see in the uterus. As in this case, you can appreciate a few anechoic structures in the uterus in this longitudinal image. But what you can see at one glance is that they are actually present in the anterior and posterior lips of the cervix and are in no way present in the upper half of the endometrium. So these structures in the cervix, anechoic without any kind of echogenic rim around them, are nothing but Nabothian follicles. Now, in this case, we do see some anechoic structure, and it also happens to have an echogenic rim. This is another structure which is anechoic, though it's not very clear. It seems to have some echogenic strands within it, but it has an echogenic wall. Now, is this truly a gestational sac? Let's see in the next clip. This is the clip of the same patient, and what you can appreciate here is that this anechoic structure with the echogenic rim that I showed you is nowhere in relation to the endometrium. It's actually within the myometrium, and you can see that the adjacent myometrium is actually showing fan-shaped shadowing and hyperechogenic islands. So this is actually a cystic area or myometrial cysts seen within the myometrium in a case of adenomyosis. So one should not jump to a conclusion based on just the presence of cysts with echogenic rim in the uterus that they are a gestational sac. So whenever you see a lesion which is anechoic, first see its location, whether it's in the cervix or the uterus. If it's in the uterus, whether it's in the endometrium or the myometrium, and then come to any conclusion. Incidentally, this patient actually had a true intrauterine gestational sac as well. So these are the myometrial cysts, but at the end of this clip, you can appreciate this is the true gestational sac, which was seen within the endometrium. It has an echogenic rim. We can appreciate some amount of normal endometrial fluid as well. So a true gestational sac in the upper part of the uterus embedded within the endometrium. This is a normal gestational sac. Again, you've seen this image a few slides ago. Is this a true gestational sac? No, it is not. It is just an irregular fluid collection in the endometrial cavity. It has this oblong kind of a shape, lacks any kind of echogenic rim of chorionic tissue around it, should not be mistaken for a true gestational sac. This is what a true gestational sac looks like. It's present within the endometrium, embedded in the decidua, and has this clear cut echogenic rim around it. So, whenever you see fluid anywhere in the endometrium, you don't just keep looking at the fluid, but also look for this echogenic rim around it. This is what we would call a pseudosac, and that is a true gestational sac. So, just as I've stressed in my previous videos, it's important that before you go on to interpret anything, you optimize your image. Especially in early pregnancy, you need to get images with good magnification so as to interpret these minute structures clearly. Whenever you are measuring the CRL, be careful. Do not end up including the yolk sac in the measurement of CRL. Don't mistake the yolk sac, say, for the rhombenkephalon of the of the embryonic head, because if you include the yolk sac, you would end up overestimating the CRL. So again, you need to get good resolution images so as to understand what part is the embryo, what is the yolk sac. Also, as I stressed earlier, do not confuse the yolk sac, which is a structure outside the amnion in the chorionic cavity, with an umbilical cord cyst, especially between the 11 to 14-week scan, because umbilical cord cyst would be seen within the amnion in relation to the umbilical cord. So